now we'll have some questions on neurology. So this is the first question. A 35-year-old lady presents with generalized weakness, diplopia, and fatigue. She had recently been diagnosed with rheumatoid arthritis. On examination, there is bilateral ptosis and weakness of abduction of both her eyes with mild proximal weakness of the arms and legs, but reflexes are normal and sensations are normal. What is the most reasonable diagnosis?
Myasthenia.
Multiple sclerosis.
So we have two answers: multiple sclerosis and myasthenia. Anything else? So, doctor, in favor of multiple sclerosis, can you please give your reasons?
Yes, there are eye signs. This eye involvement is there, and this proximal weakness of arms and legs, but normal reflexes and sensations. So the different level involvement of the nervous system. That is why.
But do you have this presentation differentiated in time? These are present together. What I mean to say is, you do not have eye weakness 6 months back, limb weakness 1 year back. To make a diagnosis of multiple sclerosis, the lesions have to be disseminated in time as well. Okay.
Okay.
So this is actually, the other doctor is correct. This is myasthenia. Why do you, in exam, if you get this question and if you do answer myasthenia, then you can be more confident of the answer because the scenario already gives you that the patient has a history of rheumatoid arthritis.
Autoimmune disease. Yes.
Correct. So any autoimmune disease makes the likelihood of myasthenia gravis higher. Okay. This patient, the signs of this patient are not just related to the eyes. They have got generalized myasthenia. Eye features are also quite prominent. So this is a 23-year-old gentleman who presents with a new onset of double vision. On examination, he experiences horizontal diplopia on looking to his far left. Okay. Next, covering of his right eye obscures the innermost image. Covering his left eye obscures the outermost image. And in the neutral position, his eye is deviated medially. He has no problem on looking to the far right. His neurological examination is otherwise normal. What is the most likely problem? You may have to read the question again.
Left-sided sixth nerve palsy.
Anyone else?
Left side is 6 nerve palsy.
Why do you say so, doctor?
Left side lateral rectus is weak. That's why deviation is medially of the left eye.
Okay. Anything else? Then how do you explain the other findings? Are you able to explain the other findings? That you cover his right eye and the innermost image is obscured. You cover his left eye, the outermost image is obscured. Do you explain this finding with this diagnosis, doctor?
Unable to answer, sir.
The answer is correct. It is indicative of left-sided sixth nerve cranial nerve palsy. So the reason is again correct, that in the neutral position, his left eye seems to be deviated medially. That means his left lateral rectus muscle seems to be paralyzed, and the left lateral rectus muscle is supplied by the sixth cranial nerve. So you have the palsy of the left lateral sixth cranial nerve. Okay. Now, as I was trying to ask, does this finding match with the other clinical examination findings? So you will have to note that in patients who have diplopia, the cover test is used to determine which eye is the problem, whether it is the left eye or the right eye which is causing the problem. If you cover the affected eye, the outermost image will disappear. That eye has got the problem. If the innermost image remains, that eye is correct. That eye is unaffected. Okay. So now with this information, does this clinical examination scenario match? Yes, doctors.
Yes, sir.
So this is just based on this is just your clinical diagnosis. What is most important is you have to find a cause, whether there is any vasculitic lesion or whether there is any vascular cause, traumatic cause, infiltrative cause, for which this is basically the investigation and the management is basically a part 2 question. Part 1 question is basically limited to diagnosis of the condition that has been presented to you. Okay. The next question is, a 64-year-old gentleman has developed diplopia. Which of the following findings would suggest a third nerve palsy?
Constricted pupil.
Why, doctor?
Pupil unreactive to light.
Give your explanation, doctor.
Third nerve palsy leads to mydriasis, I think.
Okay. What are the clinical features?
Ptosis and mydriasis.
So that is correct. So third nerve palsy, you would basically find ptosis, a dilated and an unreactive pupil, and the eyeball which is displaced downwards and outwards. A 74-year-old gentleman presents with generalized bradykinesia. Examination reveals a tremor of the hands. What is the frequency of tremor that you would suspect in Parkinson's disease?
Extreme tremor. Frequency.
Again, this is a statement question. What is the frequency of tremor in Parkinson's disease?
4 to 6 hertz.
So, what is the answer in this case?
Maybe 5.
Mm, Again, quite correct, doctor. 4 to 6 is the what has been defined as the frequency of tremors in Parkinson's. So, in this case, the correct answer is 5 hertz. "68-year-old gentleman attends the memory clinic accompanied by his wife. She has noticed that he has become progressively more forgetful over the past few years and has begun to stroll at night. Most recently, he has become lost while shopping in the local village and had to be brought home by the police. This has caused his wife significant anguish. On examination, he has easily demonstrable short-term memory loss with relative preservation of memory of events from his 40s. He also has visuospatial dysfunction. Blood pressure is 140/70. Pulse rate is normal and regular. There are no murmurs or bruise on auscultation. These are his investigative reports. CT shows mild cortical atrophy. What is the most congruent diagnosis? If you want to read the question again, then please let me know. I will put the previous slide.
Maybe Alzheimer recent memory loss.
Do you want to read the question once again, the clinical scenario?
Yes. Progressively more forgetful in the past few years. He is willing to stroll at night. From memory loss. Most practice. Issues, especially dysfunction.
So Lewy body dementia,
Why do you say so, doctor?
visuospatial dysfunction with memory loss.
Is the memory loss gradual or is it over a
Gradual.
long period of time or is it sudden?
So this is
Gradual because
Progressive.
gradual, progressive.
progressive. And what is the form of memory loss? He has short term or long term memory loss or mixed?
Short term, recent memory loss.
Yes. So what does the and there is presence of visuospatial dysfunction. He doesn't have hand-eye coordination, no awareness of his space, time. Okay. So what does all these clinical features fit into? These are the options again.
E. Multi-infarct dementia.
Multi-infarct dementia, yes. Vascular is there. It's vascular.
So in multi-infarct dementia, what you would get is the patient gets progressively worse over a relatively short period of time. That is not what the clinical scenario is indicating. He is relatively stable over a long period of time. So so this is a typical case of an Alzheimer's dementia. So the other options that you were saying, Lewy body dementia would be in a patient who develops dementia, but it is accompanied with Parkinsonian features of tremors, rigidity, and bradykinesia. Okay, there
Yes.
has to be emotional lability to indicate that the patient has got Pick's disease. So this has a normal CT, normal clinical examination, and uh, gradual onset, slowly progressing disease of a slowly progressive short-term memory loss. It is a typical scenario of Alzheimer's dementia. So this is a 75-year-old lady who presents to her general physician having developed uncontrollable chucking movements of her left arm and leg in the past few days. She had previously been well prior to the event. The movements were irregular, involving the proximal limb muscles, and did not follow a particular pattern. They occurred several times in a minute and has led to several falls. She had a past medical history of hypertension and ischemic heart disease and took regular Ramipril and aspirin. She was a smoker of 8 to 10 cigarettes per day and did not drink any alcohol. There is no family history of neurological disease. On examination, she was alert and oriented, but had several episodes of flinging proximal movements of her left upper and lower limb that made examination difficult. Tone, power, and reflexes all appeared normal, and there were no obvious cranial nerve abnormalities. Blood pressure, pulse are normal, heart sounds are normal, and these are the investigation reports, which are by and large okay. Serum cholesterol is marginally raised, and the fasting plasma blood glucose is 8.7 as opposed to 6. What is the most likely diagnosis in this lady? If you want to read the previous slides, please let me know.
Senile chorea.
Okay, anybody, anything else? Mhm. We have gone through this particular scenario today previously as well.
Yes. Hemibalismus, infarction within subthalamic nucleus.
Yes, so what is this long scenario that they have written? What are they basically pointing to?
Irregular involving proximal limb muscles and
What is the involuntary movement called?
proximal limb muscles. So it is hemibalismus.
Correct. Do you find any risk factors or anything out of the ordinary in these blood investigations?
Serum cholesterol is high,
and
so would be
plasma
due to
glucose is high as well.
atherosclerosis.
So plasma glucose
Plasma
and the
glucose
serum
high.
cholesterol level are high, which are two important risk factors for a patient developing a vascular event. So this is hemibalismus, and the site of the location is in the subthalamic nucleus. So because the patient has got multiple risk factors, the risk factors are: she is a known hypertensive, she has got dyslipidemia, she has a history of ischemic heart disease, and she is found to have diabetes as well. So the possibility of an infarction is far higher than this being a simple senile chorea. Had this been a lady with no other risk factors and all her blood pressure within normal limits, then this could have been considered, but there are too many risk factors to ignore. Okay. A 20-year-old lady presented with a history of sudden onset frontal headache and photophobia. She had neck stiffness and a temperature of 100.4. Which of the following findings would suggest a diagnosis of subarachnoid hemorrhage rather than bacterial meningitis?
Family history of polycystic renal disease.
How is that significant, doctor?
Associated with aneurysms, I think.
So what does a family history of polycystic renal disease mean? Would mean
That person having aneurysmal bleed leading to
okay.
SAH.
So what is that constellation of symptoms called? Autosomal dominant,
Polycystic kidney disease.
and that is associated with aneurysms in the
The
circle
brain
of Willis.
circle of, yeah, in the circle of Willis.
So that is the correct answer. A 54-year-old lady is diagnosed with small cell lung cancer. Despite a normal MRI scan of brain, she develops progressive truncal ataxia. Which of the following would be most beneficial in the diagnosis of her condition? So, firstly, diagnose what the patient is having, or what is this condition. Okay. So, in the clinical scenario, that it has been mentioned that the patient has got a small cell lung cancer, and on this background, the patient develops progressive ataxia. Another information that we have been given is that the patient has a normal MR scan. So that means can this signify a paraneoplastic syndrome?
Calcium.
Only time serums.
He develops ataxia. Okay. So where is the site of lesion again?
Cerebellum.
Correct. What do you find in the cerebellum? Do you find Purkinje cells?
Barmes Purkinje cells.
Okay.
So if you have antibodies directed against Purkinje cells, can that lead to cerebellar dysfunction?
Yes.
And can that lead to truncal ataxia?
No.
So that is what is happening in this patient. This is an example of a paraneoplastic syndrome which happens as a result of antibody generation from the malignant cells, and in this case they are directed against the Purkinje cells of the cerebellum, which is causing the truncal ataxia. This is a 70-year-old lady with Parkinson's disease on donepezil and L-DOPA who presents with increased agitation and inability to perform single tasks, fluctuating consciousness, visual hallucinations, and memory loss over a period of 8 months. An MR scan shows enlarged lateral ventricles as well as hypothalamic atrophy. Dementia with Lewy bodies is diagnosed. What pathological changes would be expected?
Tau tangle progression.
Okay, anything else?
amyloid plaques.
Anything else? This is a patient who has dementia with Lewy bodies. Tau tangles and amyloid plaque do you see in dementia with Lewy bodies or some other form of dementia?
Beta amyloid is in Alzheimer's dementia.
Beta amyloid is
Tau
in
tau
Alzheimer's.
tangle is in Alzheimer's.
Correct. What do you see in dementia with Lewy bodies?
C. Alpha
Alpha synuclein accumulation. Okay. Anyone else? Do we have pig body formations? So C is actually the correct answer. It is alpha synuclein accumulation. So what you see is in dementia, in Alzheimer's dementia, we generally see the tau tangles and the beta amyloid plaques which are formed. Now what we have to remember is alpha synuclein is a normal product in the brain. It gets the CSF removes it continuously over a period of time. However, if it becomes insoluble and it starts to accumulate in the brain, that is when it leads to dementia with Lewy bodies, and that is what generally happens. Okay? Pig bodies are seen in pig's disease. The last question from neurology. 71-year-old gentleman presents with a 3-month history of episodic loss of vision in his left eye. His ECG was normal and carotid ultrasound revealed a 49% stenosis of the left internal carotid artery. Initially, what is the most appropriate treatment for this gentleman? Please note that the question is asking about the most appropriate treatment.
Aspirin, sir. Third, C.
Anyone else?
Clopidogrel.
Why do you say clopidogrel, doctor?
I think dual antiplatelets are necessary, but in initial 2 weeks, they do prescribe clopidogrel. I remember something like that, along with aspirin.
Dual antiplatelets would you give in this clinical scenario?
I'm confused which will be the first preference, either aspirin or clopidogrel.
So the answer is aspirin. So this patient is having attacks of TIA, and if you calculate the ABCD score for this patient, he has a score which is greater than 4. So he does require aspirin. Now clopidogrel is for somebody you will give clopidogrel if the patient has had a prior attack of CVA and the patient is already receiving aspirin. So on only TIA or the first episode of CVA, you only have to give aspirin. If despite being on antiplatelet prophylaxis, the patient develops an episode of a further stroke or a further TIA, then you upgrade to clopidogrel with aspirin. You give dipyramidol only in those patients who are unable to tolerate aspirin because of the GI effects. You give warfarin to those patients who have some underlying disorder, if they have something like, say, an atrial fibrillation or a mechanical cardiac valve. Carotid endarterectomy is not indicated because he only has a stenosis of 49%. You do carotid endarterectomy or refer a patient for carotid endarterectomy if he has a stenosis which is above 70%. Okay?